Our next speaker is Dr. Kirk Schultz, and he's actually on our Medical and Scientific Advisory Board. Really appreciate him taking the time to come out and speak today. He is a professor at the University of British Columbia, and he has published over 95 peer-reviewed articles in scientific journals. He is a pediatric hematologist-oncologist who focuses on blood and marrow transplantation and acute lymphoblastic leukemia. Dr. Schultz was a recipient of the CIHR Wyeth the CIHR Wyeth Clinical Research Chair in Transplantation. He is the past chair of the Pediatric Bone Marrow Transplantation Consortium, the largest children's bone marrow transplant clinical trials group in the world with over 100 centers. He is a prominent member in the Children's Oncology Group, a funded clinical trials group that includes all the pediatric cancer centers in Canada, the US, New Zealand, and Australia. As an established leader in clinical trials in bone marrow transplantation and leukemia, Dr. Schultz has been involved in the development and leadership of over 50 national and international clinical trials and heads a reference laboratory performing correlative studies and Canadian Bone Marrow Transplantation Group trials. He currently is a director of the Childhood Cancer and Blood Research Group and the Michael Cuccione Childhood Cancer Research Program at the BC Children's Hospital and the Child and Family Research Institute. He is married and the proud father of 2 children. I think one of his daughters is here today. Yeah, that's great. So welcome, Dr. Schultz.
Hopefully we won't embarrass my daughter who's sitting in the back. This is a little bit of audience participation today. So I would like to, before I get going into this, ask if people would raise their hands if you have been, as a child, affected by marrow failure syndrome, have been a parent of a child affected either currently or in the past. How many people? Okay, there's a few of you. Good. For those of you that are not familiar, the spectrum of marrow failure syndromes that we see in kids is different, and I'm going to try to begin your training as a pediatric hematologist, and you're going to help me in the diagnosis, hopefully, of a patient as we talk about it as well, and you're going to learn about some of the diseases that we see. So my objectives are to try to review the most common of the uncommon, but the inherited marrow failure syndromes that we see in the pediatric and adolescent population. And second, I will talk to you a little bit about blood and marrow transplantation and how we use it to treat these disorders. And last, I'll launch into aplastic anemia and how we've been able to do some very nice basic research in this area in children and adolescents. You've seen these slides, so I'll just do a very brief review. This is your marrow and how it makes blood. We know that that's the source of our blood. We know that there's different components. There's the red blood cell or erythroid precursors. There's the platelets, which help clotting, and another major component, and then, of course, the immune system, which is both what we call myeloid and lymphoid. And all of 3 of these components tend to be affected when you have a disorder that affects the progenitor or stem cells in the marrow. And many of the things I'll be talking about actually do affect that level of marrow function in patients. So I'm going to start out. We have a little 13-year-old, or not a 13-year-old boy who was seen by his pediatrician and referred by his family doctor to us to be seen, and his blood counts were all low. Upon further questioning, his mom actually said that he had an extensive medical history, and I'll just go through very briefly what that was. He was admitted to hospital when he was 9 months old, and he had failure to thrive with diarrhea that was very bad smelling and a skin rash. He was diagnosed in having a pancreas not working very well, and he actually had to go on pancreatic enzyme replacement to replace the function of his pancreas. And he actually had some problems with his heart as well, with heart repair being required. He also had some other problems, some infections with hearing loss secondary to those infections. His bone age wasn't quite the age that it should have been, but he didn't have growth hormone failure. He also had some problems with attention deficit disorder, but his family history was negative for mom and dad being related in any way. And here's his growth curve. So I don't know if you've ever seen these type of things before, but the curves is what we pediatricians use a lot. And if you're in the kind of 95th percentile, you're going to be between those 2 bars. There, does this thing point? Maybe it does. Oh, good. you'd be in here on your height and on your weight, and you can see this boy was what we call failure to thrive and was not growing very well. And he also we did a bone marrow aspirate and biopsy, showed that he had bone marrow failure, but he didn't have leukemia and he didn't have myelodysplastic syndrome. And in fact, when we looked at his chromosomes, they were completely normal. Now I'm going to talk to you about so keep this boy in mind. We're going to go through the 4 different types, and then you're going to help me diagnose what this boy has, okay? So you're on your road to becoming a hematologist. Fanconi anemia, I'll talk to you about. And I'll also just apologize. Unfortunately, talking about this area, we have to use a lot of long names and words, and so we'll just try and go through those. Hopefully, you'll be able to work past those names and just understand the diseases themselves. This thing called Fanconi anemia, one that's called Shwachman-Diamond syndrome. And if you were a doctor long enough ago, you might have gotten your name on one of these, and that's how these names come about. Keratosis congenita, and another one called congenital amegakaryocytic thrombocytopenia. We have to have long names. We're like dermatologists when it comes to this. Fanconi anemia is something that you're born with. It has a number of congenital abnormalities, and it is recessive, which means mom and dad both have to be a carrier. There are about 13 different genes that have been identified in the world that cause or lead to this disease, and it all results in a protein not working very well and is involved in the repair of your DNA. These also, because you don't repair your DNA very well, not only do you get a bone marrow failure syndrome, but you have a predisposition to getting cancer more likely later in your life. And this is just a couple pictures of kind of the types of high increased, what we call a cafe au lait spot. Sometimes patients, I've even had patients who have no thumb, but thumb abnormalities. It's just a couple of things that will give us an idea, well, that might be a disease to consider in somebody who has marrow failure. And we do a thing called chromosomal breakage studies, where we take some agents, one is called DEB or MMC, incubate the marrow cells with them, and then we look for the chromosomes and whether they are staying normal or they don't. And what you can see is in this patient who does have Fanconi, that a number of places the chromosomes aren't nice kind of 2 lines here, which is what you'd expect, but in fact broken. So they break very easily when you expose them to certain kinds of agents. And this is one of the reasons they go into bone marrow failure with just regular stresses, and or they might go on and get cancer. Now the next disorder is called dyskeratosis congenita, and they tend to have problems with their fingernails, with the type of pigmentation on the skin, and also some white patches in their mouth, what we call leukoplakia. And this one is typically, it can be inherited in different ways. One is like your mom is a carrier, like in hemophilia, and you can pass on, she can have that pass on that one gene to a boy. You can have what's called autosomal dominant, meaning just one parent can pass it on to the next, or you can have a recessive where, again, both parents are carriers. And this is one where, again, you have a problem with keeping your chromosomes in order, and particularly this has to do with stuff called the telomeres, and these are the ends of your chromosomes. And there's a few enzymes, telomerase is what they do, and they go around and they actually keep your chromosomes in order, and the longer your telomeres are, actually, the more youthful you are. So unfortunately, as we all age, and Dr. Neville's are probably very short since he told us he was so old, but as you age, your telomeres shorten, and this is part of the aging process of a person or a cell. And if they get really short, the chromosomes become unstable and start breaking. And so this is one of the reasons that people will go into bone marrow failure syndromes. And there's been 6 genes so far that have been identified around this keeping your telomeres nice and long, staying nice and youthful in your cells, versus having cells aging too fast, too early, and starting to get all these mistakes in their chromosomes, and you shouldn't. Now here's just what a patient with dyskeratosis congenital looks like, and they'll have some of these white patches in their mouth, and some of the rashes that we were talking about. And it's hard to see, but they have nail beds that are just really don't look right. They're very kind of not formed correctly. And here's just the telomeres. You know, they're on the end of your chromosomes. If they get shorter and shorter and shorter, all of a sudden you get in some of these genes are called TERK and TERT. Here's TERK and here's TERT. And there's a few others. And they're associated with keeping those telomeres nice and long, nice and healthy, and your chromosomes do a nice job in doing their job and don't start breaking. And so what do we do to diagnose that disease? We look at telomere length and how long they are. Are they too short for your age? We see this as one of the and then this is if you have really, really short telomeres, you have keratosis congenital. And then we go on and sequence the gene to make sure that's what you have. You can get shorter telomeres for other reasons, but the ones DC patients have very short telomeres. And this just kind of summarizes they can have problems with their hair, the mouth you already saw, skin, the lungs, and various things because it's a gene throughout your body. Okay, Shwachman-Diamond syndrome. You got to remember all this because we're going to have you diagnose this patient. Okay, so they have problems with their bone marrows failing again. Their pancreas doesn't work very well. And in fact, they get into failure, and they have some problems with their skeleton. And there's some mutations on chromosome 7 associated with this one. They have problems with in their ribosome, which is a part of your cell. And again, keeping your chromosomes stable in the mitotic spindle. This is how you divide your chromosomes. And again, they have problems with their chromosomes not being very stable and breaking more easily. And the last one, these are patients who actually have low platelets, and there is problems with responding to what's supposed to make your platelets grow with this thing called TPO or thrombopoietin, and it's one of your major regulators of platelet growth, and so they have problems with good signals coming into their platelets. All right. And then I just will mention and I'm not going to get into detail about these, there are 3 other ones that are kind of in the next line of inherited things. One's called congenital severe neutropenia, one is called black van diamond or diamond black van or black van diamond, and then another one where they have low platelets and in fact you minus one of your bones, absent radius, and you're born with that. All right. So here's the diseases, as I told you about. You got Fanconi, keratosis congenita, Shwachman-Diamond, and that marrow failure, of course, they all have. Chromosomal breakage, and at least in the first 2. Skeletal problems in 2 of them. Pancreatic problems in 1. Pigment, and that. And here's your patient. So how many people think it's Fanconi? Oh, you guys are smart. Keratosis congenita. Shwachman-Diamond. All right, good. See, you guys are already on your road to becoming a hematologist. Okay, very good. So when we look at patients, we characterize them by their physical exam. It's actually quite important in looking at them. And many times, though, not all of those things that we talk about physically are present, and it makes the diagnosis quite difficult. You have a patient with marrow failure, and they may just have one of the things, or they may have a couple, and it makes it very difficult. And as Dr. Neville was talking about, some of these don't do anything to present until you become an adult. And so he said, and I'm going to have to ask you about those 7 patients, but he has 7 patients who have some of the congenital, probably Fanconi being one of the more common ones. But they will sometimes go through life fairly mild until they get into a marrow failure problem as an adult. And of course, we can sometimes see aplastic anemia or myelodysplastic syndrome or leukemias as the first presentation before they go on and get one of these diseases or come out. It's obvious that they've got a problem with their chromosome repair mechanisms. And just this kind of shows you that, in fact, up as between 50 and 75% of the time, we see the characteristics, but a lot of the times we don't see all of the physical manifestations, making the diagnosis, as a clinical doctor, just seeing them, difficult. And the red flags we'll look for are things like if they have some physical anomalies in marrow failure, they don't, and we think they had aplastic anemia, and I'll talk about that a little bit later, but they didn't respond very well to the therapies we typically use. And sometimes they'll have the young onset of cancers that are not typical for a child, and we begin to look for these as well. And there may be a family history from an aunt, uncle, grandma, grandpa, or brother, or something like that, or cousin. Early diagnosis we know is really important in these diseases. Why is that? Because the complications will build up as time goes on. We can provide genetic and medical counseling to families who might be considering more children. And the preparative regimens we use for the transplants are different. I'm going to go into that in a minute. And of course, the type of stem cells that we do, that we pick as well. And this just kind of gives you an example. Here's Fanconi anemia, somebody who's been diagnosed with that and not transplanted. This is a list, and I don't expect you to read this, of all the different kinds of cancers they can get. And so they are at a much higher risk of getting various cancers, whether it's leukemias or a kidney tumor or bone tumors and various things. And so the problem is, because of the chromosomal problems, we can fix the marrow, but you can't fix everything. And so the chromosome problems are still there as they get older. And this just goes on to talk about how the treatment also, if somebody does get their cancer, they're more difficult to treat cancers. Again, partly to do because we can't give our usual treatments as easily, because if you give regular types of chemotherapy, going back. If you give regular kinds of transplant or radiation or chemotherapy, the people have a lot more toxicities to their tissues in their body because their chromosomes break so much more easily and don't repair. And it's actually sometimes not that they break more easily, but they don't repair as well. And so you can get into a lot more liver failure, kidney problems, and things like that. And here's just how we approach when we look at any patient comes in with a marrow failure. We'll do various things in looking at the family history. Of course, we examine the patient. We look at chromosomal breakage. We look at telomere length before we go on and say you have just regular old, everyday aplastic anemia. We have to go through this. Now, blood marrow transplantation for the marrow failure syndromes. When we look at this, just to review, and anybody that's been through transplant knows this very well, but you have to get what's called a preparative regimen, and that's a chemotherapy and/or radiation. What does that do? It clears out your own cells to make room for the new cells to grow. And why that's necessary is because if you don't do that, the immune system that you have of your own will reject those donor cells very quickly and eliminate them, as it should be doing. That's what its job is. So you have to really severely damage that recipient's immune system to allow the new donor cells to go in and grow. Otherwise, they won't grow. And of course, then we follow that by infusion at what we call day 0 of the donor cells. Now, if we look at the preparative regimen in marrow failure syndromes, those that are inherited, we have this problem with chromosomal repair and breakage. So if there are too many recipient immune cells left, as I just said, we have a graft failure. So that means the graft doesn't grow, and our whole project, the whole therapy failed. If we have problems with this chromosomal damage, and we gave regular doses of radiation, or we gave regular doses of chemotherapy, those patients will get severe toxicity to organs in their body and probably die or possibly die just from the therapy before we even get the infused cells in. And so we go to what are called reduced intensity regimens. So these are ones trying to clear out most of the cells and give it room for the new donor cells to come in and take over for the damaged marrow and not cause kidney failure, heart failure, lung failure, and those sort of things. And of course, we go to 3 different sources: marrow, peripheral blood, and umbilical cord blood. As pediatricians, we of course like cord blood a lot. And in fact, now half of our unrelated donor transplants are umbilical cord blood. And one of the other big things we worry a lot about, if anybody's had a transplant, I'm sure you heard about this or may even had some of this, is the thing called graft-versus-host disease. And this is the chronic form of the disease, and it can be as bad or worse than the person's own disease that they are being transplanted for. So we always have this in the back of our mind as we try to provide a safe and effective transplant to a patient. And because otherwise they can develop into some, and this girl here is a girl with aplastic anemia that I was involved way back in the 1980s with her transplant, and she got very severe chronic graft-versus-host disease. Although her aplastic anemia never recurred, that was not the problem. Okay. And so when we look at the donor sources, if we want to use reduced intensity, we want to go for something that gives us really good engraftment, and so that tends to be marrow or peripheral blood is the best. Okay, cord blood's not very good. Not when we used reduced intensity. But the good thing about cord blood is we can actually almost always find a donor because we can go to bigger mismatches. And that's one of the reasons we do so many in children, in particular for leukemia. But the graft-versus-host disease is also really nice and low with cord blood, and is actually quite high with the peripheral blood transplants. So as pediatricians, we don't like those kinds of transplants. And also cord blood, we can get it very quickly, usually within a few weeks versus 2 to 3 months, usually for an adult donor. But the preparative regimen, we want to use a reduced one, and giving it with cord blood, we can't do it. It doesn't work. We've established that. So we are stuck with a higher graft-versus-host disease, slower obtainable donor source to give that reduced intensity. And so typically we do marrow with a reduced intensity as our standard approach for these types of diseases. We'd love to use cord, but we can't. And it's one of the big questions in pediatric transplantation right now. We're still struggling with what do we do? And I'm going to show you one thing that we have done on another patient in a minute. So Fanconi, just to briefly show you about transplant for these diseases, unfortunately, only curative things for the marrow failure and all of these inherited diseases I just talked to you about is marrow transplantation to date. Gene therapy may be down the road, but gene therapy has had tons of promise and very little output on what it's doing to help patients. And so reduced intensity and fludarabine has been a major drug in attempting to remove irradiation with some of the older ones with very low doses of irradiation. And the outcomes are actually now gone from 50 up to almost 90%. And there's a recent study by the Minnesota group who's been a real leader in transplantation around Fanconi anemia. And with the addition of fludarabine, you can see the survival rate for this high-risk population of Fanconi anemia patients has really significantly improved. And this, again, this is survival curves. I think you guys have gotten used to seeing these where you look at what's your chance of being alive after your transplant and how many years or months, and this is months out the other way. I'm going to show you a few more, and that's why I said that. Secondary cancer is still a problem we have to deal with, and those people have to be monitored for a long period of time for other cancers developing. And and GVH does appear to be a risk factor, and it's about a 40% risk in a 15 to 20 year period after their transplant, so it still exists. Shwachman-Diamond, the patient that you had, if they get their transplant, the earlier the better for that patient. They do have malignancy issues still down the road. Again, we use the reduced intensity. There are some additional problems potentially with heart and lung toxicity, and their overall survival is around 60%, although again, we worry about leukemias and myelodysplastic syndrome developing later. The dyskeratosis congenita patients, they also have their marrow failure, and again, the earlier we do the transplant, the better off for the marrow failure problem. And it is our only way. We use the reduced intensity, and we have to use the adult marrow, as I've already mentioned. Now, here's your second patient, doctors. Please put on your hats again. You now have an 8-year-old girl. She came from Texas to us, and about a year and a bit ago, 2 years ago maybe, came to our clinic, and her marrow was not working well, and her immune system didn't work very well. Letter stated that she had had physical abnormalities as well, so we saw the little girl and see what was going on. She'd had a lot of recurrent infections, respiratory-wise. She'd actually almost died of a mononucleosis is caused by the Epstein-Barr virus. She almost died of that, and did come through and survive it, but it was really a devastating infection when she was 5 years old, and so about 3 years before we saw her. Her mom and dad were first cousins, suggesting a recessive gene is real possible, and she did have 3 other older siblings, all in very good health. No history of immune deficiencies or early infant deaths. Of course, some of the sort of things we look at, is there something carried in this family? And when we examined her, we found out her head was a little smaller than we expected it to be, that her dentition was crowded to more than it was. She had some pigmentation on her skin, and she had some problems with her bladder. Her marrow, when we checked it, a hypoplastic marrow, which was getting worse and worse. And we also found that she had no B cells in the immune system, which is part of your immune system to fight and make antibodies. And that's not a usual thing that you would see in any of the 4 things I've talked to you about to date. We knew that she was going to be at risk for life-threatening infection with this lack of B cells, and she had now gotten so hypoplastic she was on transfusions, and so we knew that a transplant had to be done in this patient. So, just to remember, whoops. So you've got all of these different diseases here. We've talked about those. And what we did was we started working that up, just like we talked about. Did the DNA breakage studies for Fanconi? Normal, not Fanconi. Did telomere length? So we thought it was probably dyskeratosis congenita. It was normal as well, so it's not that disease either. So we're back to our list. And our patient doesn't really fit this, and here are a couple things, but they don't have anything that really fits any of these 4 syndromes or the other 3 that I mentioned to you that I didn't get into depth about. So what do we do? So what we did was we got a skin biopsy on this girl and took some fibroblasts and put them in culture. And there was a lab in the Netherlands that did this test for us. And we were able, they actually just exposed the cells to irradiation, and it turned out her chromosomes broke very easily. Now we know with that type of thing that there's very rare diseases associated with, they have to do with non-homologous end joining, or NHEJ, and there's a whole pathway here of various things in there to keep your chromosomes in order in this, using this pathway. And so we didn't know which one of this was. We were beginning to suspect it, so how do you sort this out? Well, one of the nice things that's now available in 2010, 2011 is you can go ahead and look at all of their chromosomes and do what's called a loss of heterozygosity analysis, doing a SNP analysis. And so what we did, we took her 3 siblings, we took her, And what you can see is all these dots here looking for things to line up. And if you share them with your siblings, it's probably not the mutation because they would have the same disease as you do. So what you do is you look for something that she has and her siblings don't have in the various loss of heterozygosity. And of course, they do a very nice job of marking it for us. And there was an area on her first chromosome that showed up as a lost region that was abnormal or not right. So that all of a sudden, now we knew exactly where to go to try and do sequencing of a gene through the genes. So we were able to do that. And we found out, and sure enough, she had a mutation with a thing called a frame shift and a premature stop codon in the gene. In this NHEJ pathway, it ended up being this last one, which I can't pronounce the first word, but we call it XLF. So we now know she's the 9th described person in the world with this mutation, and we know what to begin to expect, and what do we do to try and transplant her and give her curative therapy. Okay. So, and we went on and looked at the protein, and here's the girl here. We looked at that protein. We looked, this is just a control thing. You know, you have a protein just expressed in all cells. She didn't have it. So we've confirmed the diagnosis in this girl. Now, if you have this, what we know about the disease is that it causes your genome to be unstable. It results in these things called DNA double-stranded breaks. And you can have this just happening secondary to ionizing radiation, get some so giving her radiation therapy as part of a transplant, really bad idea. Just like with a Fanconi patient or somebody like that. And in fact, this will lead just spontaneously to replication errors in your chromosomes and additional problems with your bone marrow. So we knew that this is, not only is she going to have problems with her cells, but she's going to have problems with cancer in the future as well. And other groups had shown that there's big problems with rearrangements and repair problems in their DNA. So we needed to do a transplant, but how are we going to do it? Because one of the problems we found out was we only had umbilical cord bloods available for this East Indian girl. The problem is we don't have a lot of people in the marrow banks that are outside the European, Japanese, Chinese types of bases, and we don't have a lot. So and we have to use this reduced intensity. Remember I told you we've got to do that. We knew we couldn't really use a radiation. We don't want to use some of the intensive therapies, particularly what we call alkylators. And the only matches we had was a cord. And and the problem was if we give the reduced intensity with the cord, we've had enough experience to know we don't get a graft. So what did we do? Well, we had this reduced intensity, and so we wanted to use a cord, but we couldn't, and it was our only chance. And we had been recently doing some double cord transplants in cancer in children. And the reason we did this was there's actually a study that's been open. And the adults have been doing this because the cell doses in cords aren't very good. And so you can actually take 2 different donors. And in fact, that's exactly what we did, was we did a double cord transplant with the reduced intensity on this girl. And how's she doing? Well, she's about 6 months out, fully engrafted, and actually doing very well. Has a little bit of that graft-versus-host disease I was talking about, but is doing very well. And in fact, her Epstein-Barr virus decided to pop back up when we had to treat it. But outside of that, she's doing very well. And so we may be starting to see a way to help these children that have these rare types of diseases. Now I'm going to just finish up talking about aplastic anemia. So we've talked about the inherited diseases. I do want to talk to you a little bit about what's going on. And again, here's just where we're talking about telomeres. Those yellow things are your telomeres. And actually, Dr. Lansdorp here in Vancouver was the one that developed what's called a flow fish for that. His lab is the reference lab for the world in this type of assay. So we can be very proud in Vancouver. So we know that, and I'll go quickly because you've already heard some of this, but about 2.5 million per year in adults. And in BC, estimation is probably 7 to 9 adults develop immune or acquired aplastic anemia. And in the children's or the under 20-year age group, we have about 2 to 4 children a year. And then again, Tom went through some of this, so I'm going to be briefer, but we know there's some causes, but they actually don't, and particularly in the pediatric population, don't happen very often, whereas things like drugs, the congenital we talked about. And there's various things like chloramphenicol used to be a drug back, I'm old enough, that we were using that drug back in one day, effective, but it did cause aplastic anemia, so it's not even used anymore. It's an antibiotic. Anticonvulsants can give temporary aplasia. And there's a few other things that are associated, and of course chemotherapy is. And there has been some viral associations with aplastic anemia. Parvo B19, you heard Tom talk about that, and that usually causes what we call TEC, or transient erythroblastopenia, meaning your red cells are low, penia low, and they come back right back up. And there's been some association with solid organ transplantation patients developing aplastic anemia as well. Nobody really knows quite. Now, what we did was we actually looked at the epidemiology of aplastic anemia in the pediatric population in British Columbia, and we looked at the impact of ethnicity. And there was a question about that earlier, and hopefully I can actually answer a little bit of that question that you raised in what we found in British Columbia. We did an evaluation. It was between 1981 and 1999, all aplastic anemia patients seen in the age group of under 18 years of old, or 0 to 14, I'm sorry, we went 0 to 14 on the study. And what we found was that in British Columbia, that the incidence of aplastic anemia in people of East or Southeast Asian, and that basically means Chinese, Japanese, Korean, Philippine, Southeast Asia, and then what are called South Asian, which is people of East Indian descent, and for BC that's primarily people of Punjabi descent, there was a much higher rate, 7.3 or 6.9, versus Caucasian and mixed, which was about 2. Okay? And when we looked at it a little bit, the actual characteristics are different because Caucasians have this ratio of about 4 to 6 for a male to female, whereas, you know what, that's flipped around, guys. I just realized that. I've had shown this slide on how many times. Anyway, it's flipped around, but it was basically there's a difference in the female to male between the Asian and the Caucasian. I'm going to have to fix that. Okay. And when we looked at them, we also looked at occupational hepatitis. Now, remember, in kids, there really isn't not much in the way of occupational risks. You know, you're talking about 14-year-olds, 13-year-olds, 12-year-olds. And we also looked at whether they were born in Canada or not, because we thought that potentially the environmental factors, as Tom had raised as a possibility, might be an issue. And what we found is, in fact, at least 2/3 of the Asians, those with the high incidence, were born in Canada, not in Asia. And in fact, we could not put an environmental factor, such as pesticides or toxins or anything like that, as a reason for the higher incidence. So we think it's actually something inherited. One of the things we did look at was we looked at, well, what about some of the immune typing, how people respond to there, and this is called HLA typing. Is there any association? It has been published in Turkey and a few other places that certain HLA types lead to people having more aplastic anemia. And sure enough, we did find differences around one that's called DRB 0901 and one around DRB 1501, which was the one in Turkey. So differences in those two HLA types being higher, meaning that the way your immune system responds is different than somebody else's who might not have that. So people are slightly different and unique in how they'll respond. Depending on your HLA type, we're all unique in that way. So obviously, we know that in aplastic anemia, there's a lot of immune response, what we call anti-self or autoreactive T cells, and this whole possibility that there's an interaction with a certain type of HLA-DR types with development of aplastic anemia. I'll just show you briefly, there was an old study looking at microarray where they just kind of looked at a bunch of patients with aplastic anemia at the NIH, and what they saw was basically that there's a bunch of stress response genes being upregulated. Well, that didn't really tell us much because we know it's a stress environment anyway, so it really didn't give any kind of cause. So if we're going to try and figure out the cause of aplastic anemia on a genetic basis, it has to be done differently than it is right now. We know that antibodies probably play a role. There may be some things around cellular inhibitors of hematopoiesis or making new red cells. And interestingly enough, the actual inflammatory type of T cell responses at the time of aplastic anemia is shifted back to a more tolerant type of phenotype in patients that are successfully treated. And this is just a picture showing here's your stem cell over on this side, and that you will have T cells responding against the stem cells, leading to them going off and dying, and you go into marrow failure. So we think it's a T cell part of an immune system response, although nobody's totally sure. There's a lot of data that points that way. Now, and then I'll just briefly mention, and I think it's been touched on a bit already, that telomere length shortens in patients who have aplastic anemia. And again, it's probably a stress response rather than a cause. Not like this keratosis congenita where you're born with problems with keeping your telomeres short. This is more of a stress, and the patients that have shortening of their telomeres are they have less stable chromosomes, and they will be more likely to go on and get other problems such as myelodysplastic syndrome or And they'll also tend maybe to not be as good in treatment, and that's been some of the data that's come out. So they tend to be the non-responders, those that have really short, if their telomeres don't lengthen back out. If you're successfully treated for aplastic anemia, most of those patients, most people will go back to having the type of normal telomere length that you should have when you were, before you developed aplastic anemia. Now, we have a paper that was just published a couple months ago. Just want to show you the recent experience of BC Children's on the treatment of aplastic anemia. Okay, I'm doing okay. I was told I had a timer that would, okay, good. I tend to talk too fast. So, all right, I'll slow down now. All right, so what we did was we just took a look at all of the children that have been seen for aplastic anemia in British Columbia for a time period. And let me give you a little bit of a background on when you look at why did we do this. We know that most people recommend that you get a sibling donor transplant. Tom presented that as kind of the standard way that you would go ahead and do that. And of course, you all know about immune suppressive therapy. You've heard about that, where you use the anti-thymocyte globulin, the cyclosporin, and steroids. And there have been a lot of groups that have used not only those three drugs together, but they've also used growth factors. And what I mean by growth factors are things called GCSF or GM-CSF, a granulocyte colony stimulating factor, or GM stands for granulocyte macrophage colony stimulating factor. Both have been used, more in Europe probably than North America, but certainly by different groups. And what it does is, the idea is to try and stimulate a better response in aplastic anemia, and it seems to, in the papers published, improve the response rate by 10, maybe as high as 15%, but more around 10% higher than you would if you just use cyclosporin A2G. So it's become a popular way. If you can get a little bit higher response rate, why not use it? But there's this whole question around, if you do this, some of those papers have also shown that people have gone on to be more likely to develop AML or myelodysplastic syndrome. And there's this whole question about, remember we talked about the telomeres shortening in a stressed environment. And it may be that you're actually stressing some patients, or you're causing remissions in certain patients who are already predisposed to getting leukemia. Nobody quite knows. But it may be that by driving the hematopoietic system a little faster than it should, put the pedal to the metal, so to speak, by giving these growth factors, you are actually causing a shortening of the telomeres just by the rapid proliferative responses, and they're proliferating faster than you want to. And so therefore they can't quite keep up on keeping their telomeres in a simplistic kind of way, if you look at it that way. Which I think simply, so I always think of these things this way. So anyway, in the study we did is we said, well, let's go back and look. What was our experience at BC Children's, where we've been doing a lot of immune suppressive therapy? And so we had a standardized approach that we've been using for a number of years. We wanted to look at our survival. OS stands for overall survival. Morbidity means, how sick do people get. And we wanted to look a little bit about transplant versus IST. And then we also wanted to, because a lot of people said, well, if you use immune suppressive therapy, you are much more likely to go on and get myelodysplastic syndrome or AML, and everybody should go to transplant. There is that opinion that's out there in the treatment, in hematologists treating. And I'll just show you the response rates. Here's the response rate for between 1 and 5 years of age. Here it is between 10 years and older, and the in-between group. And so you can see, as the children do get older, we have a slightly lower response rate, and that would suggest one of the reasons that you're marching more toward the adult type of aplastic anemia potentially as you get older. Overall, though, our 5-year survival was 96% in all the aplastic anemia patients treated with immune suppressive therapy. Our failure-free survival, meaning that they didn't have recurrence of their aplastic anemia, was 63%. Our 10-year overall survival is 90%. And that's not perfect, but we're getting there. And we had no infection-related mortalities. We had infections, but we didn't have anybody die of an infection. And here's just the overall survival curves that we had there. And again, this is whether your overall survival or you had an event, meaning basically your aplastic anemia came back, and over a 10-year period, 15-year period on this curve. Okay, so we think that's pretty encouraging. And so the relapse rate was about 12%, 13%, and we only had 3% of our patients go on and develop either myelodysplastic syndrome or leukemia. So we think immune suppressive therapy is actually a pretty good way to go in treating all patients with this low MDS rate, and those that fail then go on to transplant. So in fact, and I'll just say, in transplant, we didn't have that many patients that got transplant. They all did well. Those that were transplanted right up front with a brother or sister, all engrafted. We did have one late graft failure 5 years later, but it was no better than when the patients that got the immune suppressive therapy up front. Patients that failed immune suppressive therapy and went on to get either a sibling donor or an unrelated donor transplant, we again had high engraftment rates. We had to struggle with graft-versus-host disease. We did have some graft failures where it didn't grow, one here in the unrelated donor, and so those are some of the issues around bone marrow. So bone marrow transplant in and of itself is, of course, not a perfect way to approach, and especially we think with the less toxic immune suppressive therapy, if we can treat them with that first, and only when they fail do they go to transplant. This is different than all pediatric hematologists think, so we are beginning to ask for a shift in the paradigm of treatment. And in fact, I have to now go and defend our thoughts at the American Society of Pediatric Hemonc in the spring and present what we think is maybe the way we should be as pediatricians changing. So our conclusion was we really had a good response rate, really good survival, low evidence of patients going on to get myelodysplastic syndrome or leukemia, and that we're proposing now, and we've just, as of 2011, implemented that every single new aplastic anemia patient that it gets immune suppressive therapy, even if they have a sibling donor. And that's what we've been doing this year. And overall, we've had 4 patients so far, all doing pretty well. Again, it's just our first year, and we only have about 2 to 4 patients a year. Now, and this is just the protocol we use, which is, and I think the other thing we feel is, even though the response rate is slightly low, giving the growth factors is a bad idea because our MDS rate is low because we think we're not giving it. And again, that's an opinion, but that would be comparing it to other data out there. Now, I'm going to just end up with a little bit of research that's going on in our center, and actually this is partially funded by the AAMAC through the C17, which is a funding organization for pediatric hematology and oncology. So we think actually platelets are going to tell us something about aplastic anemia. And remember, platelets are the guys that go around sticking, stopping you from bleeding and things like that. And I'll just tell you a little bit about why we think that. So a long time ago, we had 2 patients come in that were aplastic anemia patients. One was 7 years and one was 8 years off of immune suppressive therapy, in remission, doing great. And they came in complaining of, both of them ended up, and it was funny how the serendipity of medicine, these both happened within about a month or 2 of each other, came in with some nosebleeds and had a little bit of oozing of their gums around when they brushed their teeth. So not necessarily is that terribly worrisome, but it's enough that we wanted to look at it. And so we did the usual bleeding study, looking at factor 8, which is a hemophilia factor, and some things like that. And we saw that that was all normal. But we also did another test called a bleeding time, which is where we actually kind of do, and it's an old test, which we don't do anymore, but at that time we did. You puncture the skin and you just actually measure how long does it take somebody to bleed. And what that does is it tells you the non-clotting factor side of things, the platelet side. And what we saw was they were long. And so this suggested a platelet problem, and so we decided to go ahead and perform some platelet studies, and these are called platelet aggregometry. Nice. So I told you long words all along. And it's even worse. It's called lumiaggregometry is what we use. And what happens is, and here's a platelet, electron microscopy, and what you can see is that they're these little guys. They actually are blebbed off of the megakaryocytes, these cells, and they don't have a nucleus or anything, but they do have these little granules called dense granules. And they're just little parts of the cytoplasm of these megakaryocytes, and they go around and they're sticky. They last about 7 days in your blood, and then you have to have them replaced. So what happens is they'll stick to things, they release what's inside these granules, and they become the bricks in a clot. Basically, I always think of the clotting factors being the mortar, pulling the bricks together, which are the platelets. And here's just a bunch of platelets kind of clumping together there, and so you can look at how they clump together. They like to do that. That's what they're supposed to do. So anyway, you can do tests, and you can actually take your platelets and you stimulate them, and they add some plasma. They measure the changes in light absorption as they clump together. And this is what the aggregometry is. And then they can also look at what's inside those granules being released and measuring that as well. So you can do 2 different things. How well do they clump together? And they look at how the light is absorbed, and they can look at what's being released by the granules. Okay, so here's a platelet aggregometry. I told you, you're going to become a hematologist today. So this is, they get the stimulus here, and then you'll see there's what's called the, there we go. So they use their agonist. This one is ADP. Then you look at the light transmission with the platelet aggregation. And you'll have increased luminescence with the release of the granules. So they're measuring the granule release here, this green line. And then the lag time for the shape to change, that's what they're measuring here. And then they measure the first wave, what's called the first wave, there's this, and you can kind of see there's a little bit of a dip there, and then there's the second wave. Okay? And platelets, depending on how, if they have any abnormalities, can have different parts of those all being kind of a little bit off, not right. Okay? So we checked one of the patients who didn't have any of this oozing, an aplastic anemia patient, just to check to see if their platelets were okay. And we did all the stimulation, and basically what we saw was they had this very nice normal curves. We used, here's a control, and this patient here's the patient on the right. And we gave him one of the stimuluses, which is called collagen. And we also gave him another one that's called ADP. There's a bunch of them used. I'm just showing a couple of them. And basically this patient here was normal. So that's great. So one of our aplastic anemia patients, we checked him as normal. But what about the ones that had the nosebleeds? So we went and looked at them, did the same kind of tests, and what we saw was basically we had this low response of release here to one of the stimulus, and when we looked at the response to this ADP, here's the normal control on the right, and you can see they get the first, what that's called the first wave, but the second wave never happens. So there's something wrong with their platelets. They're not working quite right. They can still form a clot, but not nearly as well as somebody who has a totally normal functioning platelet. So there's something wrong. Okay? And even worse, they didn't release any ATP. I forgot to say that. Okay. There's your wave. Okay. So we said, well, okay, if they're having these, and this was happening more than one patient, we actually checked and found 3 patients out of 6 patients had this type of abnormality. So we said, well, there must be something wrong with these platelets, and it's part of aplastic anemia. Why is it happening? And by the way, these people don't go on and have major bleeding problems. It's a very minor bleeding problem. We just got a little lucky and picked it up. And so we said, well, we think whatever's happening in the platelets is happening in the immune system as well. And because your genes are your genes, they're all the same in each of your cells, so if you got something wrong here, it's going to cause problems over here as well. So we managed to put in what's called a grant to get some money from a group called the C17, which is for pediatric hematology, and the AMC actually did a partnering, and our hypothesis was these platelets, whatever's going on here, is the same thing going on in the T cell, one of the immune cells. Now, unfortunately, we've had a little bit harder time getting hold of all of our samples. We're just getting toward the end of it, but I can show you data, if you want to call it hot off the press, basically from our hematologist yesterday. And so we've got 26 patients nationally. This is a national study. We've had a little bit of problems getting all the samples, so we're actually getting some from Portland right now, finish this up. And out of those, 9 of those patients had abnormal platelets clumping together, and that's about 35%. So 1/3 of the patients with aplastic anemia in the pediatric population have this problem. So what we're going to be doing, and next is we're going to be looking for the genetic differences in these patients, in their lymphocytes. And we'll be looking at those that have the platelet abnormalities, aplastic anemia patients, those that are aplastic anemia patients that don't have it, and we'll actually have some controls, just normal age-matched controls. And we hope that by, you kind of saw how you can do genetic analysis and start picking out genes that are different. You can do something very similar to what we did to diagnose that little girl, similar types of approaches and find genes abnormalities that may be characteristic actually for development in a certain population of people for aplastic anemia. Okay? And that's it. Thank you very much.